First of all, I want to so I don't know all the oral surgery things you want to talk about, but during the pandemic, we were on many chain texting as stuff comes up. I mean, all my friends out here, they all see you as the authority. And so what I want to start you first is obviously COVID-19. That's on everybody's mind. So the first question I'm going to ask you, Jay Reznick, dentist, DMD, MD, are you going to take the vaccine?
You bet. Yeah, I don't want to get sick, and I don't want to pass it on to anybody else. This is not going to go away. COVID or coronavirus will be with us forever if there was no vaccine, and it would probably be invading the population more than it already is throughout the world. So in addition to wearing a mask and social distancing and all that, a vaccine is one of the ways that we're going to get the numbers to go down and keep it in check, so that it's like the flu. It comes back every year. Most people got vaccinated, and it's no big deal. The problem is with coronavirus is you get all these people being sick, and especially now some of the younger people, and they're intubated in the ICU, and there's not a good treatment for it yet. So we have to have a good treatment, and we have to have a vaccine before we see the numbers come down. So I will definitely be getting it.
The Russians are coming out with a vaccine. I thought the name was genius marketing. It was Sputnik. But can we substitute just vodka for that vaccine?
I actually saw a vial where they were injecting out the first Russian vaccine, and the bottle said Smirnoff on it.
Oh yeah, but Smirnoff's not Russian though, is it? Is Smirnoff? I don't think Smirnoff.
It's a Russian name.
Is it? Let me see. Let me. That's why my mom always says God made Google. Smirnoff.
I mean, it's probably not made there now, but
Smirnoff vodka is the. Here we'll go to. Oh, it's British. It's a brand of vodka owned and produced by the British company Diageo. See, I knew it wasn't Russian. I didn't know why. Well, the coolest.
I didn't make the post on Facebook.
Oh, the funniest thing was in Russia they have the bar. It's like an ice rink. It's like a little 2 feet of ice, and they put the shot glasses there, so it's like completely frozen. Oh man, it's just
slide it down.
Oh yeah, but I didn't burn up there. But and then Jay, the other thing is you're an oral surgeon. Do you kind of feel that you need to be more COVID aware than general dentistry? Meaning that, are you going to spend money to go into negative air pressure rooms and things like that?
Did I spend money? I mean, I think everybody always looks to us, since we've been trained in the operating room, or used to being in an operating room, working under sterile conditions, as kind of the authorities. Whether we are or not, who knows? But certainly we have completely changed the way we do things in the office. So we took away all the magazines and all the coffee and water for patients and people waiting. We have HEPA air filters everywhere in the office, every consultation room, in the reception area, in the front office, and then in the operating rooms. We have 2 operating rooms that are being used right now. We have negative pressure systems. So there are these huge, look like big air conditioning units that are 99.99% HEPA filter, and then it goes through a UVC grid, so that the air that comes out is completely clean. And we do that because we want to let our patients and our referrals know that we're taking this seriously. That we are really concerned about your health, the patient's health, our health. And if we do get a patient who is pre-symptomatic, and we don't know that, we want to do everything we can to protect everybody else who's in our office.
You mind me asking, how much money do you think you dropped after COVID-19 came out doing all this fancy stuff?
Let's see. I think the units were $5,000 each. We have
for the negative air pressure rooms.
Yeah, we spent a couple thousand for all the little individual room air fresheners, about $1,000 on the sneeze guards, and then PPE. I mean, we never had N95 masks. We had to get those, and those were impossible to get for a while. I think I paid like $5 a piece for them to get some in the office from a reputable dental supply company. And then getting the gowns was difficult. In fact, you still can't get any good quality disposable gowns. So luckily, our linen service at the office is bringing us OR gowns that are, that they wash and bring back. So, those costs have really gone up. I think the costs of things we had to do to modify the office to see coronavirus patients, plus the day-to-day for all our PPE has definitely affected our cash flow situation.
What did you think of the dental insurance companies going to their local governments passing laws that dentists couldn't pass this PPE fee onto their patients or charge for the PPE fees? What did you think of that? Did you think that's
absolutely ridiculous? We estimated that the increased cost per patient for just PPE alone, not counting all the other measures we've done in the office, is about $25 per patient between all the gowns and the gloves, longer sterile gloves that go up the sleeve of the gowns, head covers, the N95 mask plus another mask on top of that, plus a face shield on top of that. So I think $25, $30 as a PPE fee is completely reasonable and understandable. In fact, we're doing that.
My boys used to always laugh at me because, I grew up in the restaurant industry, right?
Mm-hmm.
So many times we always eat out all the time because, in our house, if you want to hide something, you just put it in the oven because no one's ever going to look there. But they were reminding me, but when I was talking about this PPE fee, they were reminding me how many times in their childhood we'd be at a restaurant and Dad would say, you have 40 tables in here and you have a tablecloth on each table. I bet it costs $1 and linen. Why? Do you realize that my whole dinner would be free if you would just drop the tablecloths? And I was, I was always in that mindset. And now I'm sitting there thinking, oh my God, it's like a restaurant. And now all of a sudden, because of COVID, now we have to add a tablecloth and we have to add extra silverware and we have to add all this stuff. And
we have to take out half the tables.
Yeah, I just man,
we're at 70% volume. We added 15 minutes to every consultation appointment, every surgery appointment, so that we can turn over the rooms because they all get scrubbed down completely. And so I can only be about 70% productive with my schedule packed from 7:30 in the morning to 5 in the evening. So it's had a big financial effect on every practice. I don't know anyone who's at 100% capacity.
I do, and it means something. And what you just said, I mean, think about this. I don't want to throw any of our friends under a bus, but the ADA, Marco Vukacek says we're at 71%. You just said you're at 70%. My dental office is 70%. So when that hillbilly's saying, "Oh, I'm back to normal," well, he's not doing the 15-minute clean. He's not flipping the room. I mean, it's simple math. So when people say they're back to 100%, they're pre-COVID infection control too.
Yeah, exactly.
Do you agree with that?
I would agree with that. Yeah, for sure.
Hey, Jay. I mean, you have, my God, you have 3,000 posts on Dental Town, 19 articles, 3 courses. But during this whole pandemic, you were the go-to guy on where you think we're at now. So it's August 18th. What is your future? What is your? I know there's no such thing as predicting the future or whatever, but where do you think we're at, and where do you think we'll be at Christmas? When do you think this thing will be over? When do you think we'll run another marathon together? I mean,
that's a good question. As long as it's outdoors and we stay away from each other.
Yeah, that's the only reason the only reason I actually want to die from coronavirus is so that I don't have to ever run a marathon with you again. You're pathetic when Jay says to us, "Okay, well, I'll see you later tonight," and then, but where do you think we are in this pandemic?
Yeah, it's hard to tell. And I have a good friend who's an epidemiologist, a dentist, and she got her master's and doctorate in public health, and we talk about it. And, typically these pandemics, like going back to the flu pandemic in 1918, 1919, there's the initial peak, and then it dies down for a while as they do all the, measures to contain it. And then as people get more relaxed, there's a second peak, generally in the, fall, winter, as it starts getting colder. And not only do the numbers go up beyond where they were with the first peak, but it seems to be more deadly. So is that going to happen this time? I mean, definitely, the last couple of months, we've seen a lot of people violate the social media recommendations and, gathering together in large groups indoors with no mask. And we've seen the numbers go up. The measures that we have in place are, I hate wearing a mask. Okay. I can't wait when I get out of surgery and I get into my private office, I rip it off and, so I can have a sip of water. But wearing a mask in public is not a matter of protecting your health. It's really preventing the spread if you're asymptomatic to someone else. So you see these people that have, for example, the masks with a valve on them. And I just saw something a couple days ago that the CDC is probably going to outlaw those, because what they do, those were not designed for hospital infectious disease control. They were designed for industrial use. So they filter the air coming out, but the valve makes it easier when you exhale. And that basically is like not even wearing a mask when you breathe out. So we've got to have, the right kind of masks. We've got to wear them, even though we hate it. If you're outdoors, if I'm out running on a trail with nobody around me, I don't wear my mask. But if I'm in an area, if I'm waiting to get in to the grocery store or in the grocery store or whatever it may be in my office, in the hallway of my office building, I'm wearing a mask. And everybody needs to do that. We had one patient about a month ago. She came in and she refused to fill out, well, first of all, she refused to wear a mask. Secondly, she refused to fill out our screening questionnaire, and she refused to get her temperature taken. So I reluctantly, it was just a follow-up exam, let her in, and then went to kind of consult the authorities, and I looked at a lot of the legal decisions. If I told her she couldn't come in unless she wore a mask and filled out the questionnaire, the screening questionnaire, if I don't let her come in if she doesn't do that, is that patient abandonment? And the legal opinions of a number of attorneys was that no, it's not abandoning your patient, because all the patient has to do to be seen by you is answer a couple questions, get their temperature taken, and wear a mask, and that's it. So,
what percent of the U.S. population is only alive because it's illegal to shoot them? Jay, you're out there in LA, and I mean, a lot of people say, well, California has the most cases, but they don't realize that you got to look at a part per million, cases per million, because California has the most cases, but per million it's only 28, because California has 39 million people, which is the same population as Tokyo. To show you how weird that is. But when you look at cases part per million, deaths per million population, New Jersey's one, New York. But I'm out here in Arizona. It fell out of the top 10. We're all proud of that. It's number 11. But do you think that there's 5 vaccines in phase 3 clinical trials? Do you think we'll have one of those by Christmas?
Well, I'm hoping so. I'm hoping we'll have an effective treatment as well as a vaccine that works, that's safe. You always have to worry about when you're rushing to get something out, like the COVID vaccine, that it may not get the testing that it needs to make sure that it's safe and effective. But I think we've got a lot of smart minds working on it, and everybody's working hard, and I think they're sharing a lot of data, and so I'm hoping we're going to get there. I mean, holidays are what, 4 months away?
Yeah, and the election is, my gosh, 76 days away. Mm-hmm. But you got 76 days before you can vote for the 2020 U.S. election. But we're down to just a week or two on the Townie Choice Award. So please get your vote in there. Hey, Jay, the reason I called you and you didn't call me to come back on the show for the umpteenth time is you started www.aa-os for American Academy Oral Surgery, American Academy of Oral Surgery, providing education, training, and community to dental professionals. They, when we ask dentists what procedure they hate the most, root canals is always number one. Mm-hmm. But you're right there, number 2 with oral surgery. Mm-hmm. And there's a lot of threads on Dental Town where they, especially under oral surgery, where they say, was this over my head? all that kind of stuff. But
Yeah.
anyway, but I was just thinking, you already had your online oralsurgery.com,
Yeah.
and that's been very successful. I watched several of those videos. Everybody on Dentaltown loves it. Since you
Thanks.
already had online oralsurgery.com, what would possess you to start AA? Is it, do you call that a dash,
No,
aa-os.org?
it's just for the domain.
Yeah, but
So
what
it's
is that
AA
little dash?
dash
Is that a dash? You call that
yeah
dash?
aa-os.org.
Yeah.
So the whole idea between the American Academy of Oral Surgery actually wasn't my idea. It was the brainchild of another oral surgeon, John Robertson, who's in Hattiesburg, Mississippi, who called me beginning of the year and said, I've been kind of looking at the situation. I know you've been teaching GPs oral surgery for a long time and teaching them the right way to do it. Yet I see two things. One is that the education that these GPs are getting from other sources really isn't the best. It's not the proper mindset. It's not the proper teaching. They basically tell them, you can take out one soft tissue impaction and you can do a full bony the next day. Was obviously isn't true. And the fact for oral surgery, or actually for other dental specialties, so for a GP who, let's say, does ortho, there's an organization for that. A GP who does endo, there's an organization for that. For implants, there's an organization for that. There is no organization in the US or really anywhere for a general dentist who does oral surgery in their office, loves doing oral surgery, wants to become more educated, wants to raise the bar, and wants to hang out with other practitioners who also do the same. So we teamed up with Dr. Kian Shaw, who's in Palm Desert, and Kayvon Javed, who's down in the South Bay, LA, and then Heidi Kohlfarber, who's an oral maxillofacial pathologist. And we basically put this organization together. And our mission is to provide, as you said, a community for dentists who do oral surgery in their practices. And it actually doesn't have to be GPs. Any dentist can join, and their staff too. But more importantly, to raise the bar for the quality of CE and the quantity of CE that general dentists are going to take, or dentists will take, in order to really be confident and competent when it comes to doing oral surgery in their practice. I remember 15 years ago, you and I were having dinner at Samir Puri's house. And this is when you were...
In Tanzania?
He lived in, not Granada Hills, but
no,
North Hills or somewhere like that.
Yeah, no,
but
what was that? Was it Tarzana or Tarzania?
My office is in Tarzana.
Oh, anyway,
Yeah. So
I know the name if you said it.
Yeah, you and I were having dinner at Sam's house, and we're sitting there over hors d'oeuvres, and you said, Jay, we're going to start this new thing on Dentaltown called Online CE, and I would love for you to do some courses teaching general dentists and subscribers on Dentaltown, members on Dentaltown, how to do oral surgery and do it better. And he said, you said you've been great, answering threads, but a course would be really great. And do you remember what I said?
I think you said you give me 3 courses.
My response was, Howard, why would I want to teach general dentists how to do my bread and butter?
Oh, okay.
And you looked at me and said, you don't understand. You are in suburban Los Angeles. You could throw a rock and hit half a dozen oral surgeons. 90% of the dentists in this country are in more rural areas where the closest oral surgeon's 100 miles away. There may be a 6 or 8 week waiting list to get in to see them. And the dentist has someone in his chair with a infected, bombed out, root canaled lower molar tooth. And he knows he's got to get it out. He can't send the patient to the surgeon. And he's just scared to death. That's who you're going to help.
Well,
and I thought about it for about 10 seconds. And I said, Howard, you're a smart guy. Let's do it. And that's how I did that series of 3 on Dentaltown, and then that expanded into online oral surgery.
Well, my one of my pet peeves, and I think it's because one of my first big influences was Jack Dillenberg. I was a
Mhm.
kid out here, and I moved to. I was very confused in 1987 because I left Kansas City, and in the dental school, the hardest requirement was the pulpotomy chrome silk crown. You couldn't find a human that needed one.
Yeah.
And they would get yellow buses, and they would truck in from the poorest schools on Tuesdays. Still nothing. You'd ask the little kid, "Do you have a toothbrush? No. Do you have a floss? No. And still, no pull.
Yeah.
And then I moved out here to Phoenix, and it was just everybody all the time. He was doing 2 or 3 days. So I called the Office of Dental Health. It was Jack Hillenberg. He said, "Yeah, dude, you're from Kansas City. They had water fluoridation. You're out here in Phoenix. They didn't have water fluoridation." And that's when I started to think about, back then it was only 9 specialties. Now it's 12. So the 12 now are oral surgery, endo, perio, pediatric dentistry, ortho, pros, dental anesthesia, oral facial pain, oral medicine, oral path, oral radiology, then dental public health.
Mm-hmm.
And
Yeah.
when you're in when someone comes to you and they're in pain and you can't extract a tooth, you're not a doctor. You're a flippin' bleaching, bonding queen mechanic. You're not a doctor. And the dental public health, in fact, I hate the government. They're just mobs all over. So I never gratuitously say they should pass a law, but dentists should look inside. And I mean, imagine if you crashed on your bicycle because you were trying to pass me, and you broke your leg, and you went to the biggest hospital in LA, and they go, "Sorry, Jay, we don't do legs. We only do arms and ears." I mean, real doctors can triage whatever that. And then when I did missionary dentistry, I usually stopped doing the dentistry right out of the gate because it's a bunch of dentists looking at like really sick people and trying to fix their tooth. So I would go in town and buy a doctor, and then he would take the pharmacy. And in Mexico, you could buy out the entire pharmacy, every bottle of everything they had for $1,000. And then I'd bring him because, you had like 9 dentists doing their teeth, but I wanted one guy to do the rest of the body. And I think if you can't extract a tooth and get someone out of pain, same thing with endo. I mean, maybe you can only finish simple endo, but I don't care if it's a second molar. You at least ought to be able to open it up and get that thing out of pain. So dental public health, the sexy ones are oral surgery, DDS, MD, endodontist, orthodontist, but the ones that get no respect is dental public health. And that's what I looked at you and thought, more people need to be able to take out a molar. And maybe you don't like it. Well, maybe you didn't do it unintentionally. That's not what we're talking about. What we're talking about is your public health responsibility that, if it last patient of the day and they come in with a toothache and you can't, your oral surgeon's not going to get them in and you can't pull out a tooth, you should. I think you should turn on your license. Say, "Excuse me, somebody thought I was a real doctor, but I'm not." I'll go, have it down.
Well, I think the heart of it is, what do you learn about oral surgery in dental school? It's, you get a lecture for a couple semesters. You go into the oral surgery clinic, and, the attending there, the instructor lets you take out a bunch of periodontally involved teeth. But the difficult cases go to the residents. And then you graduate, and the only teeth you can take out are those that you can grab with your fingers and pull out. Unless, if you went into the military, if you did a GPR, you would be kind of at the next level. But, most of dental education teaches very little about how to do actually nothing how to do a surgical extraction. And that's part of the problem is dentists are then thrown into their practices, and especially if they're in a rural area without an oral surgeon close by. Patient comes in, they have, like I said, a lower molar that's been root canaled that needs to come out ASAP, and they just, reluctantly muddle through it because they haven't had the right education and the right training and the right mindset. And so that's kind of where, what helped form online oral surgery. And again, then now with the AAOS following along that same lead is in
the AAOS. I missed that, following on the same lead.
Yeah, well, because the mission of AAOS is just like what I'm teaching in online oral surgery, to raise the bar for education for GPs who want to do oral surgery, giving them the right education taught by the right people. Because a lot of what I see is, most, and, I hear all the time that general dentists like to take implant courses, surgical courses from general dentists and not from an oral surgeon, because we're so intimidating. And so they're just more comfortable. And what happens is, you have a GP teaching who was taught by a GP, who was taught by a GP, who was taught by a GP. Oral surgery, we have 10,000 hours of education beyond dental school, and we're taught how to think like a surgeon. And that means you basically learn everything there is to know about the procedure you're doing. You know the anatomy, the physiology. You can mentally walk through the procedure in your head, so you know what instruments you'll need, which ones you might need to have them handy. You're going to know what complications can occur during the procedure, how to avoid them, and if they do occur, how to treat them without even having to think about it, and also manage post-op complications. And if you can't do that, we're taught you don't do the procedure, and you start very basic, and you slowly become more and more complex as your experience allows you to move forward, and your further education does. And that's not what's happening in some of these other settings. So the AAOS, as well as online oral surgery, are committed to having our members learn oral surgery the right way, to be taught by really well-qualified, experienced instructors. And we're requiring everyone to get 30 hours per year of oral surgery CE to maintain their membership, which is a pretty high standard. And we're also going to have at some point a fellowship level and a mastership level that people can attain, because I want, if you're not an oral surgeon and you're in your office and you need to do oral surgery, I want you to know how to do it right. Okay. And if you're in, let's say, in Tarzana or somewhere densely populated, big city, and there are plenty of oral surgeons you can refer to, but you want to take out the tooth, you like doing oral surgery, know which cases you should do and which cases you shouldn't be doing. Know when you should refer, when you should collaborate with a specialist. And I always teach in my courses, when you look at a case before you and are deciding whether it's something you should do, you don't look at it and say, yeah, I think I can do that. You have to tell yourself, you have to know that you can do it. If you know you can do it based on your education and training, then all is good. But if you only think you can do it, then that's a big red flag. You should, stop right there. Put down that forceps.
Well, you made me think so many things. My mind's racing. Number one, why would a general dentist learn molar endo from a general dentist instead of an endodontist? I'm a dentist, and I went back and got my MBA, and I just speak about the business of dentistry, and I'm a dentist, and I got an MBA, and I would never, ever start telling people my endo technique or my implant. I mean, that's silly. So why is this a thing?
Well,
why is general dentist teaching specialty work a thing?
I think part of it is what I mentioned before about, the specialists being so, something to be afraid of, and that you're going to be more comfortable learning from a fellow general dentist. The other part of it is, for a long time, specialists did not want to share the tools and tricks of their trade with anybody who wasn't in their specialty. And, times have changed. We're not where we were 20 years ago. The economy took a big turn in 2017, 2018. A lot of general dentists started doing more and more procedures that were outside of general dentistry, endo and ortho, surgery, implants, and the new technology that came along about the same time
came along at the same time?
The technology, 3D imaging, made it possible for them to do it more successfully. But again, when they were looking for courses, they went to someone who didn't intimidate them. When I was in residency, we learned from the residents the year above us. We learned from the residents, the senior chief residents, and we learned from the attendings. Okay. And some of our attendings were pretty gruff, old school surgeons. It was easier to relate to the resident the year ahead of me or the resident a couple years ahead of me. But who did I learn the most from? It was the attending who had the 20 years experience and had seen it all. That's who I learned from. So the same thing. I think we're trying to change the tide of oral surgery education so that oral surgeons are more willing to mentor a general dentist to do oral surgery, and that also at the same time the dentists are looking for better sources of education from more qualified instructors. And I think and the end result of that is everybody wins, because if you don't have the tools, if you don't, if you think you can do it and you screw up, I end up seeing the patient, or my oral surgery colleagues end up seeing the patient. And, to be honest, we get tired of seeing all that. If it was something you couldn't do to begin with, you should have sent it to us to begin with, because, it would have been a much better experience for the patient. Instead of sitting in your chair for an hour being tortured, they could have come to us and we would have done it, very efficiently and very rapidly and very comfortably for the patient. So you got to think about, is it better for my practice? I know I can do this, or I think I can. Better to work with a specialist, or if you want to do it, to get more education so that you know that you can do it in the future.
So my question is, what is the politics of this? Like, my oral surgery instructor was the president of the AAMOS, Dr. Brett Ferguson, and him and Charlie White and Brett Horgan were just amazing. Yeah. But what does the AAOMS think about what you're doing with the AA, American Academy of Oral Surgery, AA-OS.org? What would they think of that?
The majority of the members still have that mindset. They're still pissed off that, general dentists are taking out teeth and doing implants, and periodontists are doing impacted wisdom teeth and doing sinus lifts, and even endodontists are taking out teeth, doing bone grafts and implants. They don't realize that times have changed, and they've got to go with the times. And so a lot of them still have that same mindset. But I've been very involved with the AAOS. I have a lot of friends who are part of the American board, and we've talked, and I said, we are not there to teach GPs or other non-surgeons to do what we do. We're teaching them to do what they were going to do or had to do it better, so that they don't have to send the patient to you to bail them out, because they knew how to do it the right way. They knew which ones they should be referring to you, which ones you should work in collaboration. And when I talk to the oral surgeons and tell them that, they start to get it. And in fact, on the AAOS, in addition to our kind of executive board, we also have an advisory committee, which consists of 6 oral surgeons, 2 GPs, a periodontist, an oral maxillofacial radiologist, and an oral maxillofacial pathologist. So we have different viewpoints. And these are all really solid practitioners, some in private practice, some are in academia, that really understand the future. They understand the importance of training dentists who are going to take out teeth and do implants and do surgery in their offices, how to think about it, how to think like a surgeon, and how to do it successfully. And so we've amassed a great group.
I know, and I'm wondering why would I bring some man on for this program when I could have brought on Heidi? I mean, you've already been on the show 3 or 4 times. Yeah. Send Heidi on. I think
Heidi's on our board, actually.
Yeah. Right. I'm looking at your board right now.
Heidi's not a surgeon, but yeah, certainly she could talk about this.
Keanor Shaw had him on the show. Jay Reznick, I've had him show on so many times that now he wears the same color shirt I have. And then John Robinson, we had him on the show. Yeah. But I haven't had Convin or Heidi, and so let's talk about. I want to talk about Heidi just for a second, because she's an oral and maxillofacial radiologist.
Correct.
And how big is that technology? Do you think that's been a real game changer in oral surgery?
It's exploded. When I was in dental school, when you were in dental school, dental radiology was basically mostly general dentists, maybe a radiologist, oral maxillofacial radiologist. and you were looking at periapicals, bite wings, and panoramics, and maybe a Ceph and something like that.
And do you remember the greatest invention in oral radiology back in the day? It was like in the 80s. Remember what it was? The greatest invention everybody talked about, when they figured out how to put an R on one side of the pano and an L on the other.
That's right.
And that was every dental convention. Yeah. We got that. That was
exciting.
That was the biggest thing that ever happened in our lifetime.
But now, of course, we've evolved. We've got digital 3D technology is everywhere. And, I don't want to speak for Heidi, but, she does what she does now from home. So the cases are sent to her to be read from dentists who have the cone beam CT units in their practices, and she reads for a couple schools, and she can do what she does from home. And she also does a lot of education, and she's going to be she has an educational website with Don Tyndall, who's at UNC Chapel Hill, who was a former president of the American Academy of Oral Maxillofacial Radiology, called DRDX Docs, and it's going to be for radiology education. And so the reason we want to have Heidi as part of our group is that radiology is a really important part of doing surgery. Having the right radiographs, having the right information, getting 3D.
What is that website? www.
It's going to be drdxdocs.com. It's not
drdxdocs.
docs.com. And hasn't been launched yet, but it's pretty close. And so, it's important as part of our treatment planning that I teach when I teach my courses. I don't just say, here's how you take out a tooth. I say, here's the patient. Here are the issues. Here's the problem. Let's look at our studies, including radiographs and 3D imaging, which I think for an impacted tooth is really critical, especially when, for lower molars near the nerve or upper thirds near the sinus. We take all that information and then we discuss the case, or I discuss the case on the video. And then I talk through the procedure saying, this is what we're doing, this is why we're doing it, and then be ready for any complications that can occur. So, I'm not teaching, and the courses, all the resources you'll have through AAOS are not teaching you to be a dental technician. They're teaching you to be basically a clinician, a doctor who, in addition to knowing how to do something, knows the whys, the why nots, and most importantly, the what ifs. And that's what makes you a doctor. That's what makes you a clinician, as opposed to just a technician.
Well, and the other thing is, if you're going to get I'd rather you get an A on the diagnosis and treatment plan, and then a CDF on your treatment. I'd rather you put in a below average filling on a tooth that needed a filling than do an A+ root canal on a tooth that needed a filling. Right. And you just got to get the diagnosis and treatment.
Yeah, the thought process, the diagnosis is critical. In fact, on my oral exam to become board certified, the oral exam, they basically give you, back in those days, they had a slide projector, and they gave you a laser pointer and a glass of water, and started firing questions at you about all these different cases where there's medical complications and different things going on. And you start going down a path. And as long as you can support every test, every radiograph you did, the treatment based on what the data shows, you could pass. It wasn't getting the diagnosis right. It was the mental procedure of the information intake, diagnostic information, tests, radiographs, and then formulating a differential diagnosis and the treatment plan for that diagnosis. That's the most important thing, is to be able to think.
So so how many classes are you gonna try to put up on this site?
Well, we've got a few number of different resources. So right now we have online oral surgery. I've got about 30 hours or more of educational content, and it's all AGD PACE.
On online oral surgery?
On online oral surgery.
So are you going to close that site and move that over to AAOS?
because our organization is only going to be a resource, sort of a conduit to get to quality education. So we'll also have access to DRDX docs. We'll also have access to the Extraction Academy. We're going to have access to an educational site that talks basically medical emergency training, how to handle medical emergencies in your office. We're going to have a website that teaches oral pathology. We're going to have every asepsis, infection control, all kinds of topics, so that you can pick and choose a la carte what courses you want to take, as long as you get the total of 30 hours per year. And as a benefit of being a member, all of these websites will give a discount, anywhere from 30 to 40% to the AAOS members when they take the courses on that, through that website, or if they have live courses, the same thing.
There's, we're coming up on 8 billion people, and everyone wants to be unique. And one way to be unique and to give yourself affirmations is to put a bunch of initials behind your name. So I love the fact that you're going to have a fellowship program and a mastership program, because sometimes those kids, they need to be validated somehow,
exactly.
to give them the confidence to say, I'm going to go pull that. And I've been there. I mean, in 32 years, I mean, a half dozen times I've started question myself, am I going to get this tooth out, or am I going to have to load them in the car?
Patients love seeing those things. Patients love seeing all those credentials and diplomas in your office. So it really helps, especially, as you're getting more, as you're starting your practice or a few years into your practice, all those additional qualifications you have are really, really great for patients to see. So that they know that you've done this extra training above and beyond, so that you can do the procedure they're in for.
So let's talk the down and dirty list of the things general dentists do when removing a tooth that oral surgeons don't do. I think the lowest hanging fruit would be the fact that they use air-driven high speeds to remove bone. I mean, what percent of general dentists, when they're removing bone, grab for their trusty, friendly high speed with
probably
air?
About 90% of them.
It's actually, I did a survey.
It's pretty high.
It's 114%.
Really?
Yeah.
Wow, I didn't realize it was that high. Yeah, they use what's there, and they don't. I wrote an article in the Journal of the ADA in 1990, I think, presenting a case of subcutaneous air emphysema. And I think I've done some CE on Dental Town about air emphysema. I've got a couple of videos on online oral surgery talking about this issue. And it's not very common, but when you see it, it's dramatic. When air gets driven into the subcutaneous tissues, and it's more common if the tissues are inflamed, from an air-water syringe, from an instrument that blows air out the front, like a dental high-speed handpiece. And, I see probably one or two a year. And for the most part, you just have to reassure the patient, put them on some antibiotics for, 5-6 days, and it'll resolve on its own. But
Jay,
it can also be very serious.
Is COVID going to change that? I mean, on Dental Town, I can't believe how many hygienists will not use their ultrasonic, and they're going to hand scaling. Do you think aerosols might be the final nail in the high-speed handpiece versus the electric? And the other thing I always look for is the reason people like to travel is because the same human had the same problem. Doesn't matter if it's a bathroom. Every toilet in every country is slightly different. So is the cupboard, the refrigerator, the dinner, the recipes. And so many advanced countries like Europe, they're all electric. And America, it's just a long cultural of plumbing in all this air. But do you think this is going to change the course of the electric handpiece and the air?
I don't think air emphysema definitely won't, because people don't even realize that it's an entity until it happens to them. With COVID, if you're sectioning a tooth or taking away bone around a tooth, you've got your high speed. I've got electric handpieces, surgical handpieces, but we're still spraying water to keep the burr cool and keep the bone cool. So there is some splash. And so even electric handpieces is not going to eliminate completely, water splashing that can splash back onto the towel or onto your gown or onto your mask. It happens sometimes, so it's not going to completely eliminate it.
Now,
But
that's just the
definitely,
difference between you and me, though, because I don't mind the smell of burning bone. So you just do that for odor reasons, right? You don't
yeah,
like the smell of it.
yeah,
You
that.
you
Yeah,
you don't
that and the
have.
patient coming back and complaining that they were in agony for a week.
So
Um,
on that list, but besides switching from electric to air, and dentists,
mm,
they're always back there and the high speeds going, and
mm.
they're just waiting for one of those. And but what besides the electric to the air do you think are the low hanging, most common things that general dentists do when removing a wisdom tooth that oral surgeons don't?
Um, well, I think one is not knowing the anatomy of the area. And in fact, I think in the article that I wrote in this month's Dental Town, I presented a case of a dentist who was trying to take out an upper third, thought he pushed the root into the sinus because he saw some yellow stuff coming out, sent the patient to my office with his assistant, and the guy was completely unaware that he had violated the buccal fat pad, and it was about 10 cc's of fat that was herniating through. So if you don't know the anatomy of the area, you can get into a lot of trouble. Placing implants or using your burr and going too far to the lingual, where you get bleeding, is not a common thing, but we've seen it from time to time. But the other thing is really the big thing is not having the proper training and experience for the procedure you're going to do. And I see this all the time. A dentist will send us a patient to have the roots taken out of a lower molar that's been root canaled that they've been working on for an hour, and they couldn't get the roots out. And you look in the mouth and the tissue is just hamburger and the patient's exhausted. And you realize they haven't laid a flap. They haven't taken away any bone. They haven't split the tooth. They haven't used other instruments that are designed for just the situation. Probably because they weren't aware of them because they didn't have the proper training. And they could have had the tooth out like us in 3 minutes if they had the proper training. So that's a common thing. And those kind of cases, really, I hate seeing those, because 9 times out of 10, patient gets up from the surgery table, and the first thing they say to me or my staff is, I've really lost confidence in my dentist. Can you refer me to someone else? Right. And that's a terrible position to be in. And everything you do in your practice should build your practice, including working with some really great specialists. But you never want to do anything that your patient is going to want to go to somebody else afterwards. And so not having the right instruments, not having the right training, not knowing the anatomy, are all kind of the most common things that I see, or not knowing how to handle the complications.
I want to go into another one. I've heard this so many times, but it hasn't sunk in that you break off a root tip. It's this little thing, and so many people quote this research on like a Bible that it's never a problem. And if it is a problem, it's only when it's being exfoliated like a splinter through the tissue. And the reason the patient got a paresthesia is because you had to get out that root tip. So what is the criteria of just, it's let sleeping dogs lie. Yeah. It's next to an inferior alveolar canal, lingual nerve. When do you leave a root tip, and when do you leave it alone?
Yeah. Well, it's funny you should mention the sleeping dogs lie, which was the old dogma. I
never heard that one, dogma.
Third molars, let sleeping dogs lie. If they're deep, they're angulated, just watch them, and then let them become someone else's problem. I saw this morning a 91-year-old woman with a number 17 with a cyst about this big around it that is now symptomatic and a problem. Okay. In the old days, they didn't have the anesthetics we have now. They didn't have the instruments we have now. They didn't have the high-speed handpieces, the electric handpieces. So it was a different time. They were using chisels and ether and all those things. But what about root tips? When do you leave a root tip? And again, it goes back to.
I got to go back to that point. Or do you want to do the root tip? Then we'll come back to that because.
Okay.
We'll want to come back to that because now that the internet, it's a global forum, and the Germans, if you meet a German dentist, you can't have a whole meal without him telling you that Germans only remove about 1/3 of the wisdom teeth in the United States, and that the United States has 5 times the cesarean rate, and they think it's all just money, that Americans pull wisdom teeth because they exist, or oral surgeons say this, but then you got that, So how do you reconcile this with German oral surgeons who think we pull too many wisdom teeth?
Well, I don't really talk to too many German oral surgeons, but what I would tell them is just what I told you, that times are different. We can get out wisdom teeth much more efficiently and safely than we used to. I mean, a typical set of full bony thirds or partial bonies takes me about 12 to 16 minutes when the patient's asleep. I mean, that's very efficient, and patient generally has a pretty straightforward recovery. A little sore, but not too bad. Because if the tooth is not going to come in to be functional, it's not going to come in to be maintainable, then it's going to at some point cause a problem, and it's going to have to be taken out then. And it's a lot easier to have the surgery done when you're 16 and the roots are only 2/3 of the way formed than when you're 91 years old and the tooth has been pushed all the way down to the inferior border of the mandible, and you've got all kinds of medical issues. So, having seen as a specialist lots of patients coming in, probably a few every month, of patients in their 60s, 70s, and 80s with a third molar that was left to lie, the dogs always wake up, and when it wakes up, and now it's a problem. It would have been much easier, had they had it out as a teenager, but of course at the time it was a different philosophy because of instruments and drugs and all that. That answer your question?
Yeah. So
Okay.
when they send in me a letter, when the dental insurance company sends me a letter, says, well, why did you remove that wisdom tooth? I said, to make up for the PPE fee.
Yeah, that's good. So the justification for taking out thirds, if they're not going to come in to be in occlusion, functional, maintainable, in a good state of health, they're going to cause a problem. And it's easier on the patient. It's easier on everybody if that's done while the patient's young and healthy and before the teeth fully form. And I think that's a pretty valid argument. Now, as far as leaving a root tip, in Europe they do, and in the U.S. a little bit, what's called coronectomy, where you basically just remove the crown of the tooth that is trying to poke into the mouth, and you basically cut off the roots and you've got to cut off the roots at least, I think it's 3 or 4 or 5 millimeters below the highest crest of bone, which is not the easiest thing to do. What I go by is, again, it's anatomy, treatment planning. If you have a 3D image and you see that the nerve is passing through the roots, that may be a tooth you want to watch. Although, 20 years later, it's still going to be the same issue. The roots or nerves still going to be in the same place, and surgery will be harder. So you have to, there's pluses and minuses. But knowing the 3D anatomy, knowing that one of the roots maybe is, has about this much lingual cortex, and if you tried to go for it, you might push it out into the submylohyoid space.
So are you taking a CBCT on every single oral surgery?
For every impacted third molar and every impacted canine.
And what
CBCT
did you go with?
I've had the Galileos in my office for 12 years.
Dentsply Sirona, right?
Yeah.
Galileo.
Yeah.
Do you know what his last name was? Do you?
Oh, Galileos, the astronomer?
Yeah.
Or Galileos, the CT?
Galileo, the astronomer. You know what his last name was?
It was, let's see, what was it? I forgot.
Galileo, because when you're an orphan bastard, he was from the city of Galileo. So when you don't have any parents, because, 1 in 10 women died during childbirth till just 1900. So when your mom has you and dies, and you're a kid running around the street, they just called you the name of the city. So his name is Galileo Galileo.
Okay.
Which
and
shows
of course that led to the Queen song, right? Galileo.
So
Anyway.
Which CBCT do you have? You have the Dentsply Sirona Galileo. Is there any number behind it?
The big full field of view. So
full field of view. Okay.
So I'll look at the tooth and I'll say, can I take this out safely? And actually having that cone beam CT and seeing in 3D where the nerve passes in relation to the roots is a big help, because sometimes you look on a panoramic and it looks like that nerve's going right through the roots, whereas in reality, it's, a couple millimeters to the lingual. And unless you're really don't know what you're doing, you're not going to disturb that nerve at all. But knowing where the nerve is, knowing the anatomy in the area, for the most part, and I tell patients when we do our informed consent, if I can see the broken root and I can easily get it out without risking damage to the adjacent tooth, to the nerve, to the sinus, or have to make a big hole so I can see it. If I can do it without doing those things, I'm going to take it out. But if I can't, then I'm just going to leave it. And we explain to them that it may just stay in place. It may migrate to the surface over years. But if that root tip is mobile, the chances are it's going to float free and possibly get infected. So if it's mobile, we try to get it. But if it's really firmly in the socket, in the alveolus, then it's much safer to leave that piece of root there. But again, you want to make sure that you're deep, at least 5 millimeters or more below the bony crest.
So I want to give an analogy about training. We were talking about what was a short list of things that oral surgeons. Mm-hmm. Oral surgeons' top concerns when general dentists perform surgery are subcutaneous error deal, not knowing the anatomy.
That's a pretty rare one.
Placing dental implants with not the proper training. I mean, let's go to my pet peeve is I do not like general dentists doing dental anesthesiology. And so there's some dental anesthesiology training people that do not like me. I'm pretty sure they're the only people on the planet. But the reason they don't like me is because, my gosh, I get the claims. One of the biggest dental malpractice deals sends me their monthly claims. And this goes back to when I started a media company, the Ferran Report in 1994, which when we had a Dental Town in 98 became Dental Town. But every month I see who dies. Whenever it's 1 million or the 3 million or whatever, they all have one thing in common. They have an IV and someone died.
Yeah.
I mean, I don't care if I place an MOD composite that ends up needing a root canal. I don't care. I don't care about so many things. I just don't want to kill someone.
Yeah.
And I don't. In fact, even my oral surgeon uses an anesthesiologist, and he does it for business purposes. He says he can work twice as many rooms. Yeah,
I bring one in from time to time. But again, you have to, there are dental anesthesiologists that do like a 2 or 3 year anesthesia residency, and they're highly qualified. That's much different than someone that took a weekend IV sedation course or, a couple weekends. And then you've got the oral surgeons where we do 4 to 6 months of general anesthesia in the operating room, putting people to sleep for everything. And then we get basically 3 years of training doing ambulatory anesthesia the way that we do it in our offices. And we have a very good safety record. California actually had the first standards for office evaluation and standards for in-office anesthesia, ambulatory anesthesia, which have now been adopted across the country. But you have to pick and choose. So if I have a healthy 16-year-old with a good airway who's coming in for wisdom teeth, I'm going to be very comfortable in, no asthma, no medical issues. I'm going to be much more comfortable to put them to sleep than this patient who is 91 years old, who has this, third molar with a cyst and a list of medical problems. And then there's everybody in between. So sometimes I bring in an anesthesiologist. I've got 2 that I use. But most of the time I do my own IV sedation or general. So, healthy young kid, I'm going to put to sleep for thirds. A 60-year-old that needs 1 tooth out, it's going to be more of an IV sedation. Conscious sedation, maybe a little deeper than conscious sedation. But, the patients are monitored. We have EKG, we have blood pressure. It's taken every 5 minutes. We have pulse rate, we have pulse oximeter, we have end-tidal CO2. We have a precordial stethoscope listening to every breath the patient takes. And we have a member of the office staff called the chinner who does nothing but maintain and hold the patient's airway open, watch the monitors, watch the chest rise and fall. And that's why it's so safe.
You play the police when you're monitoring every breath you take?
I guess I am, because I listen, because if I don't hear a breath, there's a pause for more than a couple seconds. I turn to my chinner and say airway, airway, and
I want
because you have to
I
you
want to
have to
tie
you have
this
to
in.
deal with it immediately.
I
You
want
can't wait till the O2 sat starts dropping.
I want
You have
to
to intervene immediately.
I want to add one more insight to this, kids, because one of my goals. I mean, I think old people like us should share wisdom with the kids. I mean, I'm turning 58 this month, and I'm looking at these kids coming out of school. My God, they look like. I always tease that they're in
Maybe.
dental kindergarten class. They
Yeah,
actually look like they're in grammar school. That's how
yeah. It's
freaking
funny
young.
how that happens.
Oh my God! You go in there and you think, oh my God, that's a doctor. It looks like
Yeah,
a child on your like she's lost
I
for
know.
the slipper slide. But the thing is, there's only 3 publicly traded companies. There's Dr. Daryl Holmes, founder of 1300 Smiles in Melbourne, Dr. Alex Abrams of Pacific Smiles Group in Sydney, and Dr. Raymond Ang of Q&M in Singapore. And all 3 of those are the only 3 publicly traded dental companies on earth.
Mhm,
All the other ones have gone bankrupt. And the
mhm,
only way they could go public with their venture capital people and
mhm.
the Wall Street and all that, no anesthesia, no IV sedation
Yeah,
under 18 over 65.
yeah.
So here in Arizona, who's always dying? It's always a kid.
Mhm,
And a lot of
yeah,
times it's a pediatric
yeah,
dentist
yeah.
with
Uh,
an anesthesiologist. And I'm
yeah.
telling you guys, when a pediatric dentist with a board certified anesthesiologist loses a kid in a hospital, what the hell are you trying to do this
Yeah,
in your dental office
yeah,
for? Are you out of your mind?
yeah.
And
Again,
another thing,
it's patient selection
well, I mean, God, I mean, how are you going to
and
tell
knowing what
that
you're doing.
how are you going to tell that, Jay, to a pediatric dentist patient selection when the
Mm,
Wall Street says no one under 18? I mean,
yeah,
that's their whole
yeah,
that's their whole profession. I mean,
yeah.
but Wall Street,
True.
there'll never be a pediatric dentist chain going public that's putting kids to sleep.
Yeah. But yet they do cases in the OR with
All right.
anesthesia all the time because some
Okay.
kids are not manageable.
What would you tell a kid, and that they've been out 10 years and they got their FAGD and they say, you know what, I want to learn IV sedation. I think
Mhm,
this would be a practice builder,
mhm.
and I'm in Lawrence, Kansas, and I want to do IV sedation. What,
Yeah.
what what would you think about that? I mean, they know what
Well,
I think. I think,
yeah,
what was your next worst idea?
yeah. I would say, kind of get a sense of how much you're going to use this before you take the course, but take a course that is more than just a couple weekends. Because, for me, my training in anesthesia, like I said, was 4 months in the operating room, putting people to sleep, 4 times a day, plus 3 years of ambulatory anesthesia training. Okay? You're not going to get that in a couple weekend courses. So you have to know, you have to practice safely. So you have to be able to manage an airway once you're out. You have to be prepared for patient falling into general anesthesia because sometimes it's really a delicate margin. You really have to assess the patient, but really get the right training, get adequate training, even do like a mentorship with an oral surgeon, um, and only do cases that you can do successfully. And you're not going to put them under general.
But
You're going
why
to
wouldn't you just
sedation
say,
to take the edge off.
since you know they can't get that training, they're not going to
Mm.
do a 2-year, 3-year deal, why not just have someone come into your office and do it? Why wouldn't you just
Well,
outsource that? Why
I mean,
would
a,
you
a
learn
lot of
that?
dentists do, and there are more and more dental anesthesiologists out there than there used to be. Um, I mean, if I was a GP without the training that I have, I certainly would have an anesthesiologist come in. I'd line them all up for one day, let's say the every other Tuesday, and that would be when I had all my sedation patients come in. It makes a lot of sense because and of course as we've gotten older and we've been in practice, I don't want hassles. I don't want stress. I want everything to go very smoothly and easily. I want my patients to be happy and my referrals to be happy. And if I'm struggling with someone's airway, I don't want that stress. And
Okay,
so
Jay,
if it's a pig,
what percent of your extractions are just small and large elevators? What percent do you need a forcep? And what are your top 3 forceps. What's Jay's go-to forceps?
My go-to forceps is basically like a 62 upper universal forceps. For lower molars, I like a 222, which basically it's kind of straight across, and then the beaks are broad. So it basically grasps the entire crown of the tooth. So the beaks are wider than with a universal forceps. Or for a lower molar, a cow horn, which basically goes into the furcation and then acts, I think, as a class 1 lever to lift the tooth out of the socket. So those are kind of the most common forceps that I use. And then my favorite elevator is a 46R elevator, which is basically not a super wide, but not a super skinny elevator that is bent in like a bayonet shape. And then I have the tip of it is sharpened, and I have the sides serrated, so it has more grip.
You did that yourself? You custom serrated it?
Well, people they do those things in various combinations. I did them all together. But the 46R.
But did you do it, or did you buy it that way?
No, I bought them that way. I don't do that.
Okay.
So all the instrument companies will do that for you. So those are my favorite elevators. And the other thing I use has been the approximators that I first learned about on Dental Town, which are basically like, I call them my turbo peritomes.
From Ultradet, right?
The original source for them was Carl Schumacher. I don't think they carry them exclusively now, and I think it's H&H Instruments that now has picked up the approximators. They're going to name it something else, but it's basically and I like the spade shape. It's basically like a spear that's a little curved, like the outside of a root, and you work it down the periodontal ligament space, and you rock it back and forth and go a little bit deeper. And as you do that, it expands the alveolar bone, it severs the PDL, and when you get deep enough, when it goes down deep enough towards the apex, it actually lifts the tooth out of the socket. So I've got some videos on online oral surgery where I use this instrument to have a tooth that was broken off at the gingiva, to remove it non-surgically and pluck it out with a hemostat. So those are kind of my favorite instruments.
So when you say categories, oral surgery, so if you go to onlineoralsurgery.com, he's got Oral Surgery 101, the basics before you start.
Right. That's where I tell everybody to start.
You have 30 videos on there, right?
Something like that. I can't even remember how many we have, but it's 31 and a half hours of content right now.
That is just so amazing. Hey, we talked about legally the lawyers aren't going to let you go public if you're doing your anesthesia. It's so damn dangerous. Just don't do that. Have someone else do it. We talked about there's probably more trauma to the patient trying to get out a root tip than not. Same thing on sinus
if you don't know what you're doing. So you have to have a plan. And again, going back to residency, when I was a general surgery resident, we were always taught you do everything with belt and suspenders. You have a plan and a backup plan, and maybe a backup to the backup plan. So you know what you're going to do if, for example, the crown breaks off. You're not going to just sit there with the elevator dinking away and after an hour send the patient to the oral surgeon. You're going to have to do it. Before you do it, you have to have a plan. But it's also knowing all the different instruments. And that's something else I do on online oral surgery is I teach you about the instruments that you probably haven't seen that I learned about in oral surgery residency, plus all my years after. So straight elevator and a 62 forceps. You definitely need more than that to do successful surgery. You need to have the right tools. It's like being, in the kitchen. You like to cook, Howard? I can't remember.
Hell no.
Okay.
So
you ignore what I'm saying, but everyone else will understand. So if you like to cook, and you're really into it, you have the right tools. You have the right knife for cutting bread. You have the right knife for cutting meat. You have the right tool for getting the stem out of the strawberry. You have the right tool for slicing the avocado. So having the right tools makes the job so much more efficient and so much easier. I mean, if you've ever tried to slice French bread with a butter knife, you know exactly what I'm talking about. So having the right tools and knowing about the right tools is really important.
That's a phrase I haven't heard in a long time. So belt and suspenders. So, you keep your pants up, you got a belt on. Well, a suspenders is a backup. So the saying, belt and suspenders, that you got your primary belt, but when it all goes south, you got suspenders on.
Yeah.
And that's just tough. Jay, another one, we talked about they don't have a PPE fee. Then I made a totally crass joke that from now on, whenever a dental insurance examiner sends me a deal, what do they call that? Review or?
Yeah, review.
What is it?
When they're sending it, asking why you did something. Yeah, it's just basically an insurance review.
So my joke is whenever they send in a review, I'm just going to write, I did this because you didn't give me a PPE fee. I had to bill out something creatively. That's a joke. But another thing that is being looked at is when you extract a tooth, that you should bone graft. And my God, as soon as I started seeing fees for this, I knew this was going to take off regardless. What is the criteria for I'm extracting a tooth? Should I bone graft or not?
Well, my criteria is basically if you're going to have an implant to replace that tooth, or if you're thinking of it. If you're maybe 25% sure or more sure that you're going to have an implant in that site, then we do the bone graft. If you're not going to replace the tooth with an implant, if you're going to do a bridge or just leave the space, you don't need a graft. But we all know, all the studies show that once you take out a tooth, that ridge starts to resorb. And in some patients, it may take 20 years, and some patients, it may take 20 days. And then you go back, 3 months later to place and plan the implant, and there's not enough bone, and you got to start over. Now you have to, instead of preserving the ridge, you have to build it up, which is much more difficult. So in my practice, I tell patients, if you are, if you're thinking of getting an implant, or you will, that's when we bone graft. It's kind of the insurance policy to make sure we're going to have enough bone in 4 months when we go to place the implant. Sometimes if I've got a lower third molar that, like a horizontal that is right up against the back of the second molar, I may graft some bone to try to get kind of enhance the bone regeneration distal of the second molar. But it's not that common that I do that.
Interesting. That is very interesting. When I was in dental school, the guy placing the implants, that was ramus frames, periosteals, all that. Yeah. And I thought it was so disrespectful how everyone in the school called them butchers. They're just butchers.
It was brutal surgery. Yeah, I did a number of those in my residency and saw a bunch in dental school. It's a brutal surgery. Thank
but
goodness
they were
for
the
Dr.
pioneers. Like right now, Elon Musk is using reusable rockets. That wasn't a thing just a few years ago. And I always notice those guys, the first time one of their subs went south, they would take their license away. And I've met oral surgeons scattered from here to South Carolina that are drunks in a trailer because they were doing these big cases and one went south. And TMJ, do you remember when they were doing condylectomies? Remember when LSU was doing those? Those disc implants.
Basically disc implants. They were doing the total joint replacements.
And that was with the most sacred oral surgeon in the country. Can you think of anybody with a bigger...
No, that was the TMJ expert in the country. Some of these, like anything else, sometimes you get so excited to bring it to market, like a coronavirus vaccine.
What was that TMJ implant called?
Gosh.
So it was an artificial TMJ.
Proplast, I think.
Yeah, Proplast. Yeah. So do you see any of those today? Are you sitting there at 2020s watching a couple things thinking, this is not going to turn out pretty because we've seen shit go south?
I don't do TMJ surgery anymore because I stopped doing TMJ surgery probably 10, 15 years ago because the majority of patients will get better with rest, nonsteroidals, and a night guard. And so that leaves maybe 5 to 10% that still have a problem. And so on them, you're going to do arthrocentesis. And 95% of those will get improvement with that procedure that you do in the office. So the number that actually needed to have TMJ surgery, at least in my practice, and I was seeing a lot of TMJ patients, was like 1 or 2 a year. And if I've got 1 or 2 a year, I'm not going to do it because I can't be proficient in something I do once or twice a year. I can be proficient if I was doing it every week, that's one thing. But you've got to be proficient in what you're doing. You've got to be up to date on what you're doing. Just anything that we do in surgery, don't do something you haven't done it in 10 years. Don't do it. Send it to somebody who has that expertise. So it's the same thing, with dental alveolar surgery or implant case. If you don't have the experience and the training, don't think you can do it. Refer it to someone and work with them. It's only when you know that you can do it that you should do it. And I could do TMJ surgery 20 years ago, but not anymore. I'm out of practice. I haven't done orthognathic surgery in about 10 years. And so I wouldn't, someone comes to me for orthognathic, I refer them to one of my colleagues who does.
So the TMJ right now, as a specialty, do you think that's going to fall under oral facial pain, oral medicine, oral path, oral radiology, or oral surgery? Who's going to be?
Probably oral facial pain. What I've noticed, at least in my community and others, is that the former TMJ specialists or TMJ clinics all became sleep apnea clinics, and they're not seeing TMJ patients anymore. So I think really the universities that have a facial pain clinic are really the best way to go. So if I have a patient that their dentist made them a night guard, I put them on non-steroidals, rest, sometimes Botox injections, sometimes muscle relaxants. If that doesn't work, they go to the facial pain clinic. There's a couple of them in Los Angeles, and that's how I do it. Because at that point, I'm not going to take it any further, because if they ultimately need surgery, it's not going to be me. So I may as well refer them early.
I think. Do you agree? True or false? To reach dental nirvana, you should become a dual specialist, pediatric dentist and oral facial pain, so you can hear the kid screaming while his crazy mother is holding him. You get the crazy.
Drown out the TMJ patients. I've never heard of that combination, but I guess maybe it's something. Maybe you should start a program.
What percentage of your TMJ patients are crazy older ladies? I mean, this is Dentistry Uncensored. Tell the truth.
I would say 10% of them are kind of crazy, and you can tell
10%
by how they
are kind of crazy.
Yeah,
but
at least in my practice.
What percent are female?
I think it's probably about 60%. No, 75%.
I must have some bias. Maybe I'm only remembering.
But most
the
of them
ones.
are fairly reasonable. But I always have them fill out a TMJ questionnaire, and you can always tell who the crazies are by how much writing is on that form. So someone who's not crazy will fill out the form, in the lines, and they'll just put, one or two words. Someone who's crazy will write like big sentences on, for every single category. They have every single symptom. And I wish I could just send those directly out the door, but I'll see them and then pass them on to usually TMJ clinic.
Yeah. Yeah, TMJ. I mean, I love pediatric dentists, because you just got to be thinking, what the hell is that person thinking?
Mm-hmm.
I want to spend 40 years with screaming, crying kids. Okay, good for you. And then what was the next idea? I want to be a TMJ person with a bunch of stressed out. I mean, they all got the big eyes, the crazy eyes.
Yeah,
crazy.
No, there's definitely a percentage that are crazy. But when I think about TMJ, I think about it as being a joint disorder. So, the TM joint is the joint that articulates the mandible to the condyle to the glenoid fossa, and there are different things that can affect it. Systemic disease. So if you have arthritis, that can certainly affect it. If you're a bruxer, that increases the wear and tear on the joint, and it can cause arthritis just in that joint. If you've got a jaw asymmetry, and you can't get a good bite, or there's all different kinds of things that can cause a joint problem to develop. Just like if you've got one leg that's 2 inches longer than the other, and you walk around without getting that corrected, your hips are going to start hurting, your spine's going to start hurting, your knees are going to start hurting. And does that mean you're crazy? No, it means you have an uncorrected underlying problem. So, you always have to, that's another part of surgical training is, someone comes to you with a complex complaint like TMJ, you try to figure out what the underlying problem is by getting, diagnostic tests and examining the patient, and that will help you treat them much more successfully.
Jay, it's pretty obvious that during this pandemic we have not had a central messenger plan from our, the HOA. I mean, during World War II, as soon as Pearl Harbor was bombed, Franklin Delano Roosevelt had every CEO in his office. They had the whole plan in a week. Well, dentists are getting mixed messages. The OSHA says that we can let the patients take home the extracted teeth. The CDC says, I don't know. Dentists are thinking, does coronavirus change the, who do we listen to? CDC? Do we listen to OSHA? Do we listen to you?
I think we listen to common sense, and there's so much information out there. Part of the problem is we've never seen a virus like this before. We've never had a worldwide pandemic spread so quickly because of international travel. And so, it took us by surprise, and nobody really knew what it was going to do. And of course, we didn't have a vaccine or a treatment that was effective. And so, they were kind of draconian at first with this lockdown, but then there's always the people that think it's a government conspiracy and don't want to cooperate. But and you ask, it's like, the old adage, you show an X-ray to 10 dentists and you'll get 12 different opinions. So every epidemiologist, every virologist, every infectious disease, every public health doctor, they all have a little bit of a different opinion based on their training and their experience. And so you have to kind of synthesize that, and that I think should have been the role of government, is to really synthesize all these different ideas and come up with a unified national plan. Even though there's variation in the infection rate and hospitalization rate from state to state and county to county, you need to have a standard. And that's, I think in Asia, they're very strict. Everybody does what we tell you. Everybody wears a mask. Everybody stays at home, and that's how they get it under control.
Well, you've lectured all throughout Asia, haven't you?
No, I haven't been there. No.
My God, Asia is. That is not America. That's like comparing New York City.
No, it's different. Well, in fact, look at New York City. Look at the COVID rate in New York City, New Jersey, and Boston. It's dropped down dramatically because they put everything on lockdown. And of course, a lot of people left for the Hamptons. But they basically locked down the city.
But I wasn't talking about corona. I was talking about the extracted teeth. So you have 4 bloody teeth, and you just always handed it to them. And now people are starting to think, in the middle of a pandemic, maybe you shouldn't be handing Margaret 4 bloody teeth to take home.
We basically, if they're taking the teeth home, we soak them in peroxide for about 10 minutes while they're in recovery before we give it to them. Some patients want them, some don't. If you disinfect the teeth, it's no worse than, it's their own blood. It's their own saliva that's on the tooth. Unless someone else in the family handles it without the tooth being disinfected, you don't have to worry about teeth sneezing and spreading droplets. I think it's fairly safe, and we've always disinfected the teeth before we give them to the patient. And I think if you follow that protocol, if patients really want their teeth, we let them have it.
I make a lot of money.
I like to follow common sense.
Well, I like to keep their teeth because now everything that sells is all natural. So toothpaste made all naturals. You take human teeth and you mash it up into a paste. So I take the extracted teeth and then mush it up into an all natural toothpaste and then sell it for premium dollars.
Yeah.
No one's bought any yet. Would you like to buy some?
I'll buy some. What's the brand called?
So let's
toothpaste.
So you, my gosh, I want to name so many of your videos. Success versus failure with the all-on-4 procedure, COVID-19, an epidemiologist perspective, essentials of implantology and guided implant surgery, basic guided implant surgery, Astrotech system EV, basic instrument setup for implant surgery, aseptic protocol for dental implant surgery, I mean, you just got and by the way,
we try to cover it all.
And
everything that you would learn in an oral surgery.
And the questions Jay was sending to me when he was making these, I mean, talk about the right camera, reshooting it, 3 different cameras. I mean, I've been in your office. I mean, this is just amazing stuff.
Yeah, and we're constantly upgrading everything.
But what I want you to remember is this. What confuses me is, like, when I went to the Pain Institute, I went there, it was a week-long course for like 6 weeks, and the boys loved it because it was on an ocean, whatever. But, but most of us were sitting in there, and TMJ was like 1% of our revenue, and we're spending a whole damn week on this stuff. So when people are always asking me, well, Howard, would you recommend I learn molar endo or Invisalign or place implants? Well, where are you, and what is the demand, and what are you referring
and what do you
out?
enjoy doing? Even if there's a demand, if it's not something you enjoy doing, don't do it.
Yeah, one of my best friends tells everyone he'd rather be taken out in his backyard and beat with a stick to do a molar endo. And I remember in about '89, I finally said, "Dude, there's 4,000 endodontists. You gotta quit doing this to yourself for $1,000 bucks."
I haven't done an endo since 1987, so I'm proud of it.
So what is on these implant essentials of implantology on online oral surgery? Are you buying per video, or is it a fee and you can listen to all 30 hours?
That was actually a video promoting a class that I was teaching, and we're going to be teaching again this November. I teach the essentials for dentists who've never placed an implant, or they've done a half a dozen implants, or they took a course 3 years ago and haven't placed any implants yet. I teach you the fundamentals, and it's the same philosophy like we've been talking about for the last hour or so, is totally understanding what you're going to do, being able to walk through it, understanding the physiology, the anatomy, the biology, the pharmacology, which instruments to use, how to evaluate the situation, how to handle complications, and starting really basic. So first premolar to first molar, plenty of keratinized tissue, plenty of bone, so you don't have to lay a flap. You can do it with a tissue punch. That's where you start. Once you've got some experience, you've done 20, 30 implants, then you can do cases where you have to lay a flap and then have to suture it, or do 2 implants next to each other, or think about maybe anterior aesthetic zone. It's all a progression. You got to crawl first, and then you got to take baby steps, and then you got to walk before you can run. And
I want to also tell you some facts. Jay was the first person ever to pass 10,000 views on the courses that we put up when we started doing online C with you. And at the and then when I looked at that list, only 3 people had passed 10,000 views, and it was only you. It was 3 for 3.
Yeah.
And that was in so that was amazing. So I mean, that the proof is
Howard, where's my check?
Back then we didn't even charge for it. Remember that?
Yeah,
we didn't even charge. But so you also have some trial courses. So it says 30-day trial membership videos.
Exactly.
And
so
then
sign up for that. It's free.
So those 5 videos are all free?
It's about an hour to an hour and a half's worth of videos that are free. And then if you like what you see, then you can sign up for either a monthly or an annual plan.
And what's the monthly fee in the annual plan?
$50 a month, or $4.95 a year. So if we do an annual, it's like getting 2 months free. And it's really, I think it's really reasonable for what we have there. And we've got a lot of content. Where else can you get, if you watch everything, 30 straight hours, where are you going to get 30 hours of CE for $4.95? It's not going to happen. So I think it's very reasonable, and you can do it from your office, from your home, when you're on vacation, sitting on the beach. I mean, that's
well, they all get it now.
That's going.
The one thing, so what I've been coaching my 4 boys is that, when the Berlin Wall fell, the world reorganized differently. When the Arab uprising, when 9/11, I said you can't have the whole country, the whole world fall upside down, and it's not going to reorganize differently. And my gosh, the one thing that it did is it sped everyone up into this future of working from home, working online. Yeah. I mean, why do you got to get in an airplane and fly from Phoenix to Miami. That's 5
Right.
hours.
Yeah.
And stay in a hotel and
Yeah.
then register and all, to go listen to some oral surgeon talk for an
Yeah.
hour. I
Yeah.
mean,
I
it's
think I think you're a little bit more engaged when you're actually in a big room. But I think a lot of people go to those meetings for camaraderie. They go to see their buddies. They go to see their colleagues, and go to the parties and the social times. Um, if you could, if that's one thing that obviously is missing in a virtual conference. I mean, that's why I go to things, is to see my old residency mates, see some friends from dental school that are oral surgeons, take some courses from people that don't have an online educational site that I want to learn from. And it's not, it's nice to be somewhere different, for a couple days and then go home. But definitely, this pandemic has completely changed the whole landscape of how we're doing everything, how we're getting our education, how we are holding meetings, how we're, everyone's a lot of people are working from home. A lot of people can do the same thing sitting at their kitchen table than they can do if they're sitting in an office. Unfortunately, we can't do that. We've got to be hands-on. But definitely, I did a lot of phone consultations during, when we were only in the office a day or two a week. But this has changed. I think, who knows? This may change the face of dental education, medical education forever. I mean, if you talk to the reps of the various, all the big companies, the ADA meeting or the California Dental Association meeting or AO, or not AO, but Chicago Midwinter, or all these, they all tell you the meeting attendance seems like it's down, but for sure they're seeing less traffic at their booths and selling less.
I can't believe we're coming up on 2 hours, and I know you're going to shoot me.
No
but
way.
I've got yeah. But anyway, I gotta rifle through some questions real quick.
Okay, sure.
The big debates that just won't die. It won't die. Septicane versus lidocaine. Septicane causes paresthesia. Blah blah blah. When it never holds up in court. Can you use Septicane or not?
Oh yeah, I use it all the time. The only thing I don't use Septicane for is a mandibular nerve block.
Well, that's half the shots on Earth.
I know that it's just as safe, but just. It's kind of it's just kind of a CYA
So
thing.
you just use Septicane on the upper and lidocaine on the bottom?
I use Septicane for my buccal block, for infiltration. I use it for everything except the inferior alveolar nerve block.
Okay.
Yeah.
Number two.
I mean, Septicane penetrates better. It's a more profound anesthesia.
I don't want to throw dentists under a bus. I think the 11th commandment is dentists shall not badmouth other dentists. But my God, you know how many of my drinking buddies, after every extraction, Pen VK 500 milligram and 16 Vicodin. Do you what percent of these wisdom tooth or molar extractions do you think are overprescribed antibiotics and opioids?
I think a lot of them. I mean, my protocol for, let's say, a third molars in a healthy patient, there's no existing infection around the teeth. I have them do chlorhexidine rinse starting 2 days before and finish off the bottle. About
finish off the bottle. Now that caught my attention.
So 2 weeks with it. And so, the 5% that come back that have an infection, then we treat it and we debride out the sock and put them on antibiotics. If it's a case where I'm going to be, taking out an infected tooth and placing a bone graft, I start the patient on antibiotics a couple days before. If it's a high risk patient, so if I'm taking out in a partial bony, full bony impacted third molar that's symptomatic and pathological on a 45-year-old guy, they're at the highest risk for post-op jaw fracture and osteomyelitis. I'm going to cover them with antibiotics. A diabetic, even if it's a straightforward extraction, I'm going to cover them with antibiotics, but they're way overused. So I only use them in selected cases. And as far as the opioids, I can't remember the last time I wrote a Vicodin prescription. What I do is I tell the patients to take 2 Advil and 2 extra strength Tylenol together every 6 hours. And there are multiple, like around the clock for the first couple days. There are multiple studies in the orthopedic literature and in the emergency medicine literature showing that combination is as effective, if not more effective, than Vicodin without any of the side effects. And I'll give them as a backup some tramadol, which is a fairly mild narcotic. It's, and most of the patients never get it filled. But the Tylenol Advil combination is great. And sometimes I have a hard time believing that the dentists are causing the opioid crisis, because generally we're seeing the patient for a particular problem. They had a surgery and then they get their post-op meds. Unlike some specialties where you're treating someone that has chronic pain, where they get hooked because that's the only way they can get through the day. So, if a patient comes back to my office a week after surgery and they're still having pain, then I remember the old adage I made up when I was a chief resident. When things don't seem right, there's a good chance that something's wrong. So if they're having pain a week after surgery, they shouldn't be. Go in, see what's going on. See if there is a bony sequestrum. See if food got stuck in the socket. See why they're having pain. Just don't give them pain medication and send them out the door. So you always have to ask, why is this happening? And what's the best thing to do?
Yeah.
I rarely prescribe anything stronger than tramadol.
Today in the newspaper, it's all over the news. It's all over Dental Town. It's a very long thread under oral surgery. A Pennsylvania oral surgeon is accused of altering records of drug usage to conceal her drug use. And I remember back in '87, that was always a moral issue, and you need to have your license taken away and go to jail. And it was so nice to see that the dentists started treating it as a addiction issue, and they need to go to the Betty Ford Center. And I remember saying this to McCain. I said, well, anyway, I don't want to go there. I'm in Arizona. But the bottom line is, how come all the rich dentists will get an attorney and go to the Betty Ford Center, and then all the poor people? I mean, we have 3 million people in the prison, and probably 1 million of them are for addiction. Yeah. But what's the chance this rich oral surgeon will have to be treated like all the poor people in America?
Yeah, because unless they had ran into somebody and injured or killed them.
And the other thing, one of the reasons I cannot stand this issue, because everybody always wants to talk about opioids. Nobody's dying from Vicodin. It's the biggest. Nobody overdoses on Vicodin or Percocet. Those are illegal. They can't get them at Walgreens, so they go buy them on the street, and they're cut with Mexican and fentanyl. Yeah. And so why did we have more opioid over deaths than auto accidents this last year? Last year, I mean, there's always auto accidents between age 20, I think between age 15 and 30. The number one cause of death has always been auto accidents. And now it's gone to opioids. And the government's like, well, you got to say no to drugs, and the dentists can't prescribe Vicodin. Dude, they're not dying from Vicodin. They're dying from, you made all the drugs illegal, so they're buying them on the street. And they're cutting it with fentanyl. So don't you think the DEA is the one that kills more people each year than auto accidents by making all this stuff illegal? I mean, we both have kids.
It's hard to say,
Well, I mean, I got 4 boys. If my boy fell off track, I'd rather him get Vicodin from Walgreens and live than go buy some crap made in a bathtub. I mean, Prince.
Addiction in this country is a huge problem, and a lot of it has to do with mental illness. We definitely need to address.
Prince had his own jet flying around the country looking for Vicodin, and he too had to go buy this stuff off the street. He didn't die from opioids. He died from having to buy illegal shit. So the government makes it illegal so they can create jobs for 1 million people running prisons, and then more people die of drug overabuse, and then you still have people thinking the government is here to help you. It's like the government is the source and the cause of the problem. End of story. Ronald Reagan, I mean, he's out there where you came from, and he's like, government is the problem, not the solution. So we're never supposed to talk about religion, sex, politics, or violence. We just covered all of those
things.
Hey, can you score me a podcast with the DRDX Docs, Dental Radiology Education?
With Heidi and Don? Sure.
Absolutely. I would love to do that.
They're both good friends of mine.
So is Heidi Bridget Goldfarber, is she German or German?
Let's see, I think there's some Dutch in her family. I actually did implants on her dad a couple years ago.
I could see Dutch there.
I mean, she's very, white and blonde. So I think there's maybe some Scandinavian. Yeah. Yeah.
Okay.
I think she said once, but I
So
forgot.
go to so again one last time. So you have onlineoralsurgery.com, but that's still going to stay there. Your new website is aa-os.org, which stands for
the American Academy of Oral Surgery. And so it's a great organization. We're actually planning our first annual meeting for November 21st, 22nd, which is going to be virtual, of course. But we're hoping to have an in-person meeting next year. We've got a great lineup of speakers for this first meeting. We've got a lot of good resources and pathways to get continuing education. We have a lot of educational partners in industry that are partnering with the website that will provide discounts to our AAOS members. So there's a lot of good perks, and it's a great organization, great people, and really excited about where it's going to go. We officially launched it, I think, last week once we had the website and everything running, and we're getting just tons of signups every day from all over the world. So there's definitely a need for an organization for dentists who do oral surgery in their offices, because there is no other organization for them.
And it was started by Dr. Keanor Shaw, who lives in Palm Desert. You know who his neighbor is?
Reznick.
Jerry Reznick.
Yeah.
Oh, my gosh. What an intense dude. How many implant companies did he start? 3?
Well, it's the same one over and over again.
What was the first one? CAT?
No, it was
Camelog?
No, not Camelog. It was
Implants Direct.
God, I'm blanking. Corvent.
I see. I got the C right. Corvent. I mean, can you imagine?
Corvent, and then he sold that to, I think.
And you know what he's doing now? You know what he's doing now?
Rolling in his money.
Oh, he's got more money than God.
Enjoying life.
No. Those guys like that, they could never slow down. So he bought all that equipment to mill titanium. And Jerry Reznick is just a Six Sigma. I mean, he'd spend 40 hours to make it 1/1,000,000% better. And anyway, long story short, he got so certified and so intense, he finally realized, what the hell am I making dental implants for? The satellite companies, they can't, when they outsource their parts, there's all this regulation. So he has changed that whole thing to making parts for satellites, because they need really sophistication. And he said,
and really, really precision.
Yeah, and he said, coming from dental implant surgery, he was a leap ahead of the other ones and all that kind of stuff. But Keanor and Jerry live next to each other. But hey, Jay, seriously, man, thanks for making the first 3 courses. Now, those were back in 2005, 10,000 views. Thanks for being the go-to oral surgeon. Every time there's an oral surgery deal, I mean, people in Dental Town will say, "Where's Jay?" And then,
I got to try to be on a little bit more.
I mean, no oral surgeon would take the time to do something like that, and you're just a hell of a guy. Love you to death.
It's always fun. I always enjoy doing it.
And I want you to know that the only reason you beat me in those 3 Ironmans because I wanted to let you win. I was sitting back there eating chips.
You let me come in 1,212.
So hey, thanks for everything.
So I get that medal.
Last final overhead, just real quick, 1 second. What is your go-to surgical headlight? Are you using the over the patient, or are you using the miner's hat?
We have that, and I also have so most of the time, if I'm not filming, I have it's a BFW highlight, so it's a fiber optic. But on the camera that I use for filming, so when we film cases for online oral surgery, we have a camera in the overhead light, a high-def camera that's basically on my forehead that you see exactly what I'm seeing through my loops. And we have a third camera that's on a boom that a camera operator can move back and forth and into position and zoom in and zoom out. So,
and you do that while you're jamming out to Third Eye Blind?
Yeah, exactly. And so when I have the headlight camera, I've got some little LED headlights.
All right. Well, can't wait till the pandemic's over.
Whatever gets the light in the right place and isn't too heavy.
All right. Well, when this pandemic's over, we'll do dinner again in LA or Scottsdale.
Okay. Sushi it is.
All right, buddy. Have a great day.
Right. Take care. Good to see you, Howard.
Good to see you, Jay.